Stay Lit, A Prescription to Avoid Dr. Burnout, 2020, by Dr. J.W. Crosby, MD. Avoiding malpractice. Practice good medicine. Sounds simple, but it's hard to be good day in and day out and when on call in the middle of the night. Sometimes you'll be sick and crabby and sometimes just human. Go to refresher courses to keep up. Read the literature. If you're feeling sick, take time off. It's not an excuse if you make a mistake. Imagine a pilot announcing in mid-flight, "Sorry, we have to ditch in the ocean. The co-pilot and I have the flu." If you're crabby and burn out, get some counseling to help change things. Ask a respected fellow physician to mentor you. Talk to your patients. You really need to communicate and ask them what you said at the end of every encounter. If they are kids or have dementia or trouble with English or French, get help from a translator or their guardians. Give them a handout to reinforce your instructions. Dr. Walter Keene, a Hamilton rheumatologist and professor at McMaster, mails a copy of his consult letter to the patient. I wonder if he would do this if he were a gynecologist. Just asking. Tell them more than once. Talk slowly, no jargon, big words, or short forms. I usually try to avoid insulting patients by talking with big and little words. For example, you have diabetes or high sugar in your blood, or you have a fractured or broken arm at the elbow. Tell them of the major side effects of treatment or drugs. No one has time to list everything. A reasonable, prudent, and average doctor would say, "Please try some aspirin for your sore ankle. Aspirin can cause allergies or upset stomach or stomach bleeding. Call us or go to the emergency department if this happens, or if you develop black bowel movements or shortness of breath." Document this in your notes. For example, side effects explained. Be nice. I have seen so many cases where the patient said, "I love my family doctor, so don't sue him, just the other doctors." If you are nasty to patients and things go bad, they may sue you. If you are getting angry with a patient, take a deep breath and try to rise above it. Refer them to someone else if you have a stalemate. I had a patient in one of my nursing homes that drove me nuts fighting with me about everything I said, so I asked the other house doctor for a second opinion. If they are unhappy that you can't find anything wrong with them, send them to a specialist. I have been burned 3 times with seniors losing weight. A full workup with a lab, scope, CT, and gastroenterologist and even tertiary care referral yielded nothing. They later died of cancer of the pancreas. Now I meet with similar types of patients and their family and say we can't find anything so far, but we'll keep monitoring the situation. Apologize. This is a real tough one. You don't have to go overboard. Just say, "I'm sorry you had a bad outcome." You don't have to admit you made a mistake. Always talk to your insurer and lawyer before you do this. I have heard so many plaintiffs say that if only the doctor had said he was sorry, we wouldn't be here in court today. Have a good system of follow-up. That means do your lab and imaging reports and review of consult letters every weekday. Initial them and have your secretary file or action them or click on them if they are in the computer. Charting is the most important thing as the judge looks at that. The judge and plaintiff's lawyers know only too well that we see hundreds of people weekly and often can't remember the details. Try to dictate charts or use an electronic medical record. The standard of care now is becoming typed notes. Make sure you have a history, targeted physical exam, assessment with a differential diagnosis and plan. Even if you make an honest mistake, the judge will see that you were trying to be thorough. Always note that the patient was encouraged to call you or return or go to the nearest emergency department if worse or no better. Document this. For example, Call office or go to ED-PRN. Always document follow-up on every case. For example, FU/FD-PRN. Follow up with family doctor as necessary. Specific cases. Meningitis is very rare due to new immunizations, but it is devastating with death or possible permanent disability for up to 80 years if a child is involved. It is fast and can be masked as a cold or flu. Suggested notes to encourage you to be thorough and cover you if you are too early into a case. Subjective. 5-year-old girl with a cough, fever, and sore left ear for 2 days. Eating normally, no diarrhea, immunizations up to date. Objective. 25.3 kilogram, afebrile, happy child playing normally. Ears, nose, and throat normal, no palpable neck nodes, neck is supple. Assessment. Viral cold, rule out strep throat. Plan. Throat swab or rapid strep test if available. Encourage fluids, acetaminophen for age and weight, and call me if worse or go to the emergency department, PRN. Hand this out on paper. I have all my handouts in my computer for easy, fast printing. This shows that you are thorough and have developed an organized approach, and you have left the door open if things get worse. Fever in babies less than 6 months. This can be sepsis, so record the state of the fontanelles, check and record neck suppleness, and do a full septic workup, and refer stat to a pediatrician if you think it is necessary. Don't wait around for tests that may delay life-saving antibiotics. Headache. Once again, is rarely lethal, but most neuro-emergencies are devastating as the brain and spinal cord don't heal as well as the rest of the body due to the sophistication of neurons. Ask, is this new? Was there a sudden onset, and what was the patient doing? Lifting or orgasm may signal raised intracranial pressure causing a subarachnoid hemorrhage. Do a full CNS exam and BP and check for neck stiffness by asking the patient to flex their chin onto their chest and watching to see if they wince. Decreased level of consciousness and confusion are not benign signs and should not be attributed to narcotic painkillers. Do a stat CT scan and lumbar puncture. If you are in a remote area, call neurosurgery at your regional tertiary referral center. If you don't have a neurologist handy, an internist can help. Ectopic pregnancy. This should be ruled out in any woman with abdominal pain of childbearing age. They may deny sexual activity or having missed a period. Appendicitis. Can be difficult to diagnose early on. It may be on the left with a long appendix. The patient usually has anorexia, and it may be painful for them to walk due to psoas muscle spasm. Do a white blood cell count, urinalysis, and get a CT of the abdomen if available. If in doubt, admit, get a surgical consult, and reassess in 12 hours. If you are in a family physician's office or walk-in clinic and are sending them up to the emergency department, always include a referral letter and tell the patient to not eat or drink anything in case they may need surgery. Cancer can start very subtly, and family doctors may not notice some early warning signs because we are lulled into business as usual with long-standing patients. We often don't see serious disease for weeks and may miss it. Weight loss in older patients can herald cancer. Don't make a diagnosis of depression until you have ruled out malignancy and referred to the appropriate specialist. If someone has rectal bleeding, make sure there is no cancer up above the hemorrhoids. I had one case where a patient with rectal bleeding kept returning to his GP with rectal bleeding, and the doctor just kept giving him suppositories. Eventually, a surgeon found a carcinoma above the hemorrhoids on colonoscopy. Skin lesions are very hard to tell if they are cancer. If in doubt, get a biopsy. I am astounded at how many seemingly benign moles end up as basal or squamous cell carcinomas. Do a mole patrol on all patients during their annual checkups and on high-risk patients, such as those with a lot of sun exposure or previous melanoma. Lumps. Once again, don't guess, get a biopsy. I was an expert in a case where a 36-year-old lady had a breast lump in early pregnancy. Her family physician delayed referral until after delivery, and she later died of cancer of the breast, and her family successfully sued him. Fractures. I have seen elderly patients walk on fractured hips, and the x-ray was negative initially. This was because osteoporosis caused the fracture line to not show up due to minimum calcium. If they are still limping a week later, re-x-ray. With kids complaining of sore arms and minimal swelling, always x-ray, and if there is no radiologist around, do both limbs to help differentiate growth plates from fractures. Compartment Syndrome. This is a common cause of lawsuits and causes devastating, permanent damage to limbs. It can present at the family's physician's office or an after-hours clinic after a fracture or casting. The limb has pallor, pain, pulselessness, and paresthesia. The treatment is splitting the cast down to the bare skin on both sides with restoration of the circulation. If in doubt, call an orthopod or send up to the emergency department. Don't mask it with painkillers. Diabetic foot ulcers. I always treat them very aggressively because they can result in amputation above the knee. I tell the patient and their next of kin that the prognosis can be very bad and may end up with the leg being cut off above the knee even with the best of care, and I document all of this. I refer to an infectious disease specialist because they can see them fast, and I start appropriate antibiotics and wound care by home care nurses who call me daily with updates. I refer to a surgeon if debridement is necessary. I call the surgeon doctor to avoid delay in treatment, and I document this. Torsion of the testicle. Once again is rare but devastating and can be mimicked by orchitis. Always err on the side of the most dangerous diagnosis and treat both together. I get a stat ultrasound and CBC and call the urologist personally right away and document it. Murder. I was an expert in a case where a doctor was treating a lady with paranoid delusions that the TV was talking to her personally. He convinced her to go to a psychiatric hospital, but whilst on her way, she returned home and murdered her husband. The doctor was exonerated because he could not have certified her for involuntary psychiatric admission because she was going voluntarily for help. Suicide. If a patient threatens suicide, send them to the emergency department and call the emergency physician. If they refuse, call the police to have them escorted to the emergency department. You will have to complete an involuntary admission form. Document everything in great detail. What if a specialist refuses to help you in an emergency situation? Once again, this is very rare. It has happened to me twice in 44 years. I told them that I would have to call their chief of service even if it was in the middle of the night. If the chief of service couldn't help, I called the chief of staff, and if that didn't work, I shipped the patient to a teaching center. Patient care is paramount. You can deal with the politics in the sober light of day. Another huge issue is our Canadian problem of long waits for tests, consults, and imaging. We and our patients are so lucky to have a free system, but the downside is that there are often long waits. If you really think the wait will harm your patient, call the specialist and radiologist and make your case. Document this effort. You can't cry wolf too often, so only do this if necessary. Never change the chart. The plaintiff's attorneys can hire a handwriting expert to tell if the ink is older or different, and forensic computer experts can check the hard drive to find out on what date the computer notes were typed. Checklist if you get sued. A. Don't panic. Take a deep breath and remember this does not mean you are a bad doctor. Speak to no one and alter nothing. B. Call your malpractice insurer first and do what they tell you. C. Do not alter the chart, ever. D. Remember that most cases are dropped and the plaintiff rarely wins the few that reach court. In summary, to inoculate yourself against malpractice claims, be thorough, take your time, do your paper computer work and emails every weekday, refer appropriately, be nice, apologize without incriminating yourself, back yourself up, and document, document, document. 8. Less prestige. Who cares? Don't let your plumber know you're a doctor. She'll charge you double. Number 9. Lack of a unified voice. Join the teachers' union. They have to strike when told to. 10 doctors will have 11 opinions. This has been since time began and is unfixable. We are small business people. It's nice to not have a boss. Embrace it. Don't let it burn you out. Number 10. Electronic medical records. Get TELUS PS Suite. I have it and it cuts my stress. It was invented by a small-town family doctor, so it's very easy to use. It makes me go faster and do a better job. Number 11. Low collegiality. This is true. The doctor's lounge is no more for many, especially the family doctors who have left the hospital in droves. We can only hope to rekindle it with blogs, emails, texts, and educational meetings and conferences. Being able to complain to each other is key to avoiding burnout. Get a mentor. Have breakfast or lunch with fellow doctors. I do. Number 12. Bullying from colleagues. The only way to deal with a bully is with a bigger bully. Report to the Chief of Service or Chief of Staff. My own personal thoughts on burnout are that you need something to be passionate about to avoid it. It may be a subspecialty, even if you are a family physician like geriatrics or a prison doctor, etc., or a hobby or volunteering. Also, I avoided burnout by always changing up my jobs if I became bored. I have had 8 job changes in 45 years and still love medicine like the first day. My hobby is writing stuff like this.